So chapter 5, medical terminology, really important chapter. Anybody know why chapter 5 is so important? Because it's medical terminology. Very good. Now what's important about medical terminology? This is the terminology we use. Sometimes you don't learn about words, you might not, I don't know what that is, but because I can break down the word, you can figure things out. So that's the good part about medical terminology. If you could understand those stems, prefixes, suffixes. Remember learning that in school? And you probably say, why do you know this? Because they were preparing you for ENT school. Okay? So let's go with some of the medical terminology. So we got to look, some words are made up of two. Small is one word, pox is another. That's just an example, so we call it smallpox. So you'll see there's a lot of words that are made up of two words combined into one. Okay? So we'll see a lot of that through medical terminology. But we look for certain things. We're going to look for the root word, the meaning. What does that truly mean? So I'll give you an example like heat. All right, and then the root word combined with other stuff is thermometer, and then put it together. The prefix is a good one. Dis is one, dyspnea, combine it together. And anytime you see that word that starts with a dy, I don't know, cooler. Unlock it. Can you unlock it? Yeah, and unlock the other one. I think it's the other one that controls this phone. The one that's in the classroom there. So dyspnea, anytime you see that word D-Y-S, that means difficult. So the word P-N-E-A means breathing. So we put those two together, what does dyspnea mean? Difficulty breathing. I'll give you another one. Dysrhythmia. What does rhythmia mean? Rhythm, your heart rhythm. So if I put this in front of it, dysrhythmia, what does that mean? A difficulty producing rhythm. Does that make sense? So you're going to learn that word dy, dis means difficult. So dyspnea means difficulty breathing. So we use the word difficulty breathing. We might hear that, but a lot of times we refer to it as dyspnea. Patient is complaining of dyspnea or patient has dyspnea. So you know what that means now. It means that this patient is having difficulty breathing. Is everybody with me on that? Okay? Now, we use another word too in medical terminology. We use A. A means absent. Okay? So apnea, apnea means what? Absent breathing. You with me? How about arrhythmia? An absent rhythm, a rhythm that doesn't produce. It's absent of a pulse. Because a rhythm should generate a pulse. We're going to learn that later. So if I have a rhythm with no pulse, we refer to that as a arrhythmia. If I have a rhythm that's creating difficulty or a problem in the patient that he becomes symptomatic, we call that a dysrhythmia. If I have a patient who's having difficulty breathing, we call it dyspnea. If a patient is not breathing, we call it apnea. Does that make sense? So the A means we're out. So symmetrical means equal. Asymmetrical means unequal. So if I say I have symmetrical chest rise, that means both my sides are doing what? Equally expanding, right? If I use an A in front of it, asymmetrical, that means what? Only one side is moving. You with me? If I say my patient is symptomatic, he's presenting with signs and symptoms, right? If I say he's asymptomatic, he's without symptoms. Does that make sense? So when people start talking to you with this terminology, you can put it together because I understand the different stems, prefix, suffixes, and all that good stuff, root words and all that good stuff. Everybody with me so far? All right. So let's go on to another one. Tachy always means fast. As Brady is the opposite. So tachy fast, Brady slow. So tachypnea, that means fast breathing. You with me? Okay. If I say tachycardia, what does cardia mean? Heart. So if I put tachy in front of the word heart, that means what? Fast heart rate. Let's say bradycardia, slow heart rate. Everybody with me? Simple, fair enough, right? Okay. Very good. All right. Look at the next one. Itis. Arthritis. Itis means inflammation. Inflammation. Everybody with me? Okay, inflammation. So arthritis is inflammation of the bones. Phlebitis. Okay, so that's also swelling. So anything that ends in itis, we know deals with swelling, inflammation. Okay, fair enough, simple enough. All right, so we just kind of talked about this, right? We looked at, we combined the two words together. We know fast means we use fast in medical terminology as the word of tachycardia, tachy, I should say, sorry. And then we want to add the heart, we use cardia. So tachycardia means fast heart rate, as bradycardia does the opposite. Fair enough? So we need to understand what will be tachycardia. Well, we got to understand first what's a normal heart rate. Anybody know what's a normal heart rate? Say it again. 62, we get a range. 100, very good. Are you asking me, you're telling me? That's what I'm talking about. Tell me. Be confident. Even if you're wrong, be confident. You know? I'm sure we got some confident people here, right? Anybody go to the club, meet a girl or a guy, say, hey, you want to dance? No. Okay, how about you? No. And if you keep going, your odds are going to increase. Somebody's going to say yes. If you quit on the first one, then you didn't meet the objective. You with me? So, you got to be confident when you say things, because this is the job of confidence. This is a job. When you go to take care of a patient and save their life, you have to be confident in what you're doing. Because if you doubt yourself, you're probably going to go the wrong path versus go with that gut feeling. Anybody heard of gut feeling? Anybody ever say, hey, go with your gut feeling? Anybody ever heard that before? And that's true. I believe in gut feeling. I call it instinct. That's what that is, instinct. And you have instinct. It's not something you found. It's not something you purchase. It's not something that you develop once you finish EMT school. After 5 years, you develop instinct. Instinct is something you have. So you got to listen to your instinct all the time. If it's talking to you, you should what? Listen. All right? And if you don't believe that that's something you have and you're born with, I'm going to give you a great example and see if you disagree. A tiger. Better yet, let's make it a lion. A little more aggressive. A lion born, raised in captivity, been hand-fed every day. They come, drop the steak, the meat, whatever they give this lion, they put it in there. Has he hunted? Has he ever hunted? No, his food is always what? Given to him. So if you're going to tell me that this lion has never hunted, doesn't have the instinct to kill, then why we cage him? Because he'll eat you. It's instinct. This is his nature. So there's no difference. Same thing with us. We're that tiger. We have instinct. We just like to build it, and we become more confident with the instinct as we become confident in what we do. So I really want you, when you answer to me and when you do things here, I want you to be confident. If you're wrong, I'll tell you. Cool, no problem. Just continuously be confident. If you're not confident, you have doubt in yourself, people are going to change your mind all the time. If you feel strongly about something, stick with it. It's probably right. But if you're not confident, it's real easy for somebody else to change your mind. Now you're going the wrong route. And you're going to see that when we start doing scenarios. Somebody's going, yeah, we'll do this. And somebody's like, no, we should do this. Oh, okay. And it was the right thing, went to the wrong thing. So I want you to build confidence. It starts right here in the classroom. When you answer me with confidence. Fair enough? Okay, very good. Got off on attention. All right. So here goes some other words. Hemo means blood. So I know I see the word hemo, I'm talking about blood. Okay? Thorax or thoracic means chest. So I have a hemothorax. That means I have blood in the chest. What does pneumo mean? A pneumatic pump. You ever heard of pneumatic pump? What does that pump out? Air. So what's pneumo mean? Air. Very good. You telling me? Say it again. Air. Air. That's what I'm talking. See the difference? All right. Air. So if I say I have a pneumothorax, air in the chest. So you see how you can start putting these words together and you understand what we're talking about. So I say, how about if I say, let me really test you right here. The patient has a pneumothorax. Blood and air in the chest. Very good. Now people say, well, isn't that normal to have air in the chest? No, it's normal to have air in the lungs. If it's leaking outside the lungs, it's entering the chest, and that's no good. Okay, we'll learn about that later on when we get into trauma. All right. So here's another great example of putting the elements and putting words together. So cardio we know means what? Heart. Heart. Alright, and then cardiologist, the "olo" means the study. Ologist means who studies it. So a cardiologist, he studies what? The heart. Alright, very good. Alright, so sometimes we like to use acronyms. Acronyms are phenomenal. I'm like an acronym guru. I love acronyms. That's how I remember things, you know. You know, my kids' names, they create an acronym. I don't forget it. Okay? So, so sometimes that's good. So CPAP, we abbreviate a lot of things too. CPAP stands for Continuous Positive Airway Pressure. I swear, you could go out there and you can do some clinicals and you can say, hey, get me the CPAP. Boom, right here. Can you get me the Continuous Positive Airway Pressure device? You got those? A lot of people don't understand the full word because we constantly use an acronym. We use the abbreviations, and that becomes their norm. You know, and that's acceptable. That's acceptable. Some people don't even know that OMI is a line of my quiz too. Hey, you go to OMI? Yeah. What does OMI stand for? I don't know. UCF is another one, right? University of Central Florida. People now just know by UCF. So they have to think twice about what does UCF stand for. So acronyms are not bad. It's good. Easy way to remember things, but you should know what it stands for. Does that make sense? Okay. All right. DNR. We use it all the time. DNR. A patient has a DNR. That's a do not resuscitate order because that's important for us. We talked about that in medical legal. Gary should have talked about it last day. But DNR is a do not resuscitate. We have to respect and honor that DNR. That's the only. I don't know. You might see this again. That is the only. What's it again? That is the only advanced directive we honor pre-hospital. The word advanced directive means in advance, from here meaning the future. If I become incompetent, if I can't make decisions for myself because of my illness have taken over, and I can't make these decisions, this is what I want you to respect and honor in advance when my disease advances to that level where I can't make decisions no more. I want you to honor this. So when did the patient write this or accepted this order? When he was competent. Now I'm no longer competent because of my disease. Maybe I'm unresponsive, I lost my mind, whatever it is, and now I die. This is what they wanted, and the doctor agreed because you have a terminally ill disease. You could go ahead, I want you to, you could sign, I agree, we don't need to resuscitate you if you die. Because you have a terminally ill disease. The worst thing to do, for example, is cancer. A cancer patient who dies, to resuscitate them. And you were successful. Now they're back, probably at a worse state, brain dead, whatever it is. Now you, one, gave the family false hope. Because family will always believe best case scenario, not worse. They always say, oh my God, you got him back. It's a miracle of God. He's going to be okay. He's cured. No, the dying doesn't reset your disease. You don't start from fresh again now. So we want to respect those DNRs.
Could you repeat that? DNR is the only directive.
The only advanced directive that we honor pre-hospital, because there are other advanced directives. They have what's called living will. A living will is just that. I'm living, and I created a what? A will. We can't respect that. Well, we can respect it, I should say. We can't honor that pre-hospital. We can't honor that pre-hospital. A healthcare proxy is another one. We can't honor that pre-hospital. Only one that we're allowed to honor pre-hospital is a do not resuscitate.
Are there requirements for DNRs?
Yeah, there are requirements. Terminally ill patient, you have a terminally ill disease.
That's it.
And then the doctor has to sign off on it. Say, yes, you do have a terminal disease. Yes, I'm going to validate this DNR by my signature. So, and it has to be dated. Because we do have patients that are terminally ill who end up doing better. And then they just cure of the disease, whatever it is, and then now they'll revisit the order and they'll say, okay, we don't need the DNR anymore.
And if the doctor don't sign off, they don't honor it?
That's a good question. That is a phenomenal question. That's the biggest problem we have. And so the doctor does, let me repeat what she said. If the doctor doesn't sign off on it or if it expires, do we honor it? Well, are we doctors? Are we doctors? No, we're EMTs. But who do we work under? Who's a what? A doctor. So what I need to do is, I will start CPR because I have nothing that's valid right now, correct? So I got to initiate care. Once you initiate care, can you automatically stop? No, I got to get permission from who? So now I start care, and I get on the phone with my doctor. So my partner's doing care, I get on the phone, hey doc, I got a patient who has a DNR, it's expired. Or the doctor forgot to sign it. Can we honor it? He's going to make the decision. What he normally would say is, how does the family feel about this? They want us to honor it. All right, let me talk with them. Hey, do you want to honor this DNR? Yes. The doc said, can you put the EMT back on the phone? Sure. Go ahead and stop resuscitation and honor it. So our doctor could do so. That's kind of like him doing what? Signed off on that DNR. Does that make sense? So just remember, if you're not the doctor, you can't do that. So what can you do then? Start care. Start resuscitation, start care, and get on the phone with the doctor and let him make the decision. Does that make sense? And that's where we struggle a lot. A lot of people say, oh, well, give me the DNR. When you find it, let me know. I'll be right there. If they don't have it present right there, what we're going to do it automatically. So I'll work with the patient, because if not, you're kind of being neglected. You're neglecting the patient. You're negligence because you fail to what? Treat your patient. Does that make sense? Okay? All right, so that's what DNR stands for. Moving on. So, when and when not to use medical terminology. Well, do not use the certain medical terminology when speaking to patients, because guess what? They don't know it. So, hey, do you know if you're tachycardic or not? They're going to look at you like, yeah, or no. So they don't understand. So, instead of saying, are you normally tachycardic? I would say what? Do you normally have a fast heart rate? Do they understand that? Yes. But now if I talk to the nurse or the doctor, when I drop the patient off, can I use the word tachycardia? Yes, because that's common lingo for us. So we got to know who to speak with. You can't get the 2-year-old kid and say, hey, do you know you're tachycardic? He's going to look at you and probably start crying. Okay? So we got to know who to talk to. Family members, patients, and probably other patients we want to show. And some people believe, well, if I talk this bizarre lingo, that shows I'm highly educated and they're going to respect me even more. That is the biggest myth. All right? Talk their lingo, layman's term. Because when they start understanding what you're talking about, they become, one, more comfortable with dealing with you. Second, they become a little bit more calm because they're understanding now what you're explaining to them. All right? Does that make sense? Just think about you. Somebody walked in your house and started talking another language that you don't understand. You're going to be confused. You're going to panic. You're already in a state of panic because you're sick. So we got to use that layman terminology, okay? Occasionally, now, how about if I have patients and cardiologists? Can I use that terminology? Yes, because they understand it, okay? So just remember, we don't want to confuse our people. We don't want to confuse each other by trying to say one word and we say something else. I want to say you're tachycardic, and I say, hey, are you tachycardic? And what did I really say? Are you fast breathing? When I wanted to say, do you have a fast heart rate? Does that make sense? All right, so keep that in mind. So keep it simple. Sometimes I'm a believer, sometimes less is more. All right? So what does this mean? Right, so pulmonary means lung system. So I talk about pulmonary system. We don't call it the lung system. We call it the pulmonary system. So we know we're dealing with the lungs. Okay. So there's a great video there. You can watch it when you want on migrating on Canvas. And this just tells you a patient interacting. The reason why I say that, I'm not trying to be sarcastic, is my videos for some reason don't work here. All right. So I apologize for that, but don't worry. The videos are on Canvas and on my Brady Lab. You go to my Brady Lab resources, there's videos, there's all these videos are there. You can watch it 100 times. Watch it one time for class and then watch it one time on your own. Okay, so you don't feel cheated. Alright, language of anatomy and physiology. First we got to understand what's anatomy and what's physiology. Well, how we refer to anatomy and physiology to? Anybody know? We call it what? A&P. That's an abbreviation. A&P. Alright, so anatomy is the study of a body structure. Okay, so an actual organ, a structure, that's anatomy. Your heart, that's anatomy. Your vessels, piece of anatomy. Now, when I take the blood vessels, the blood and the heart together, they work together, right? The heart pumps the blood through the circulatory system. We call that the study of its function. Now we're talking about the physiology, right? Everybody with me? Now we want to talk about that system, its disease process. We call that pathophysiology. Does that make sense? Why is it called pathophysiology, not pathoanatomy? Because it's disease of the functioning of that system. Does that make sense? So once again, you'll learn this terminology because we use it frequently. So when I say, what's the physiology behind that? Then what I'm referring to? The functioning of whatever we were discussing. Okay? And you say to yourself, hey, where's the anatomy of the heart? Where does that piece of anatomy sit in your body? Now I'm referring to a organ in a specific location. Right? So where does the heart sit? Anybody know, by the way? Right, in the chest. Real simple. Keep it simple because we haven't got the cardiology yet, but yeah, slightly to the left. All right? Most people. Some people actually, the heart sits on the right. We call those people, it's a word, you don't have to know this word, but it's called dextrocardia, where their internal organs are flipped completely. What's on the left is on the right, what's on the right is on the left. We call them dextrocardia. So those really confuse paramedics.
They usually don't have a lifespan very long.
No, they actually do. They're perfectly fine. They're just flipped organs.
If all their organs are flipped.
Yeah, they just flip. So instead of the heart being slightly on the left, it's slightly on the right. Instead of the right lung being 3 lobes, it's 2 lobes, and the left one is 3 lobes versus 2. That's all. It's just flipped different. And they live perfectly fine. They just dextrocardia. So if the paramedic did a 12 lead on this side, they're gonna look at an ECG and like, what the hell is this? Well, the heart's not there on this side. That could definitely screw you up. All right? And it's not like a prank. They're not playing a prank on you. You just can't flip it back. All right, that's their anatomy. Okay, so once again, I use the term. That's their anatomy, meaning that's how their organs are structured. Okay. All right. Let's talk about anatomic terms. Very important terms. This is a term I will guarantee you'll see in the near future. Okay. It's called the anatomic position. Anatomical position. The anatomical position is the body erect. So what does that mean? I am standing up with my palms facing forward. This right here is the anatomical position. If I'm laying on the floor with my hands facing forward, am I in the anatomic position? No. No, because the body is now what? Upright. It's not erect. It's not upright. I have to be standing upright with the palms facing forward to call that the anatomical position. Does everybody understand that? If I'm laying on my back, we call that a supine position. No matter my hands forward, back, doing this, whatever. Don't matter. I'm laying on my back, I'm supine. All right, we'll talk about these positions. So remember, you see this again. If they ask you what is the anatomical position, it's going to be the body erect with the palms facing forward. Facing forward. Okay? Very good. Now, once we're in the anatomical position, we like to divide the bodies into halves and stuff to easily identify different locations, right? So if I go directly between the eyeballs, down the nose, through the umbilicus, all the way down, I just split my body into halves, 2 halves, right? The right side and... Now, this is where it becomes truly confusing. It's always the patient's right side and the patient's left side, not yours. Because if you're standing face to face, my right is your what? Left. So you say, hey, can you move your right hand for me? And he moves his right hand. You're like, no, that's your left. No, that is his right. So we always, when we refer to referencing anything, we're using the patient's right, the patient's left. Does that make sense? Okay? All right, so once again, we call that, by the way, that line that divides right from left, the midline, in the middle. So it divides 2 halves. Okay? Now, we use two words. Once we divide that in half, we use a lateral word and a medial word. Lateral means I'm further away from the midline. As medial means I'm closest to the midline. That seems a bit confusing, but let me give you how we use that terminology. So midline, if I say my lungs are bilateral, that word lateral once again means what? Further away. So bilateral means the word bi means what? 2. That means I have a lung on each side of the midline. So I have bilateral lungs. If I have only one lung, we call that unilateral. Make sense? Now we also use it as a point of reference. So I'm sitting, remember, what position we reference everything off of? Anatomical. Palms facing forward. So, midline, right? Is my elbow closer to midline than my wrist?
Yes.
And we're going to use the word proximal. We're going to get to that. Actually, scratch that. I'm going to come at the next slide. Right? I'm getting ahead of myself. Let's talk medial lateral. Okay. Anatomical position, right? My pinky, that's thumb, making sure you're awake. My thumb, we agree, is further away from the midline than my pinky? Would you agree? Who's closer to midline? Pinky. So my thumb is further away, right? So then we'll say my thumb is lateral to my pinky. If I flipped it the other way, my pinky is what compared to my thumb? Medial, because my pinky is close to the midline. So we use the word medial, close to the midline, lateral, further away. Does that make sense? All right, I got another one for you. My ear is what compared to my eye? Lateral, because it's what? Further away. If I flipped it, my eye is what versus my ear? Medial. Everybody get that? Everybody confused? Anybody can do that one more time? All right, we're good? Perfect. So if you think about medial and lateral, we're talking more of left to right. And then we need to know what anatomy we're referring to, what anatomy we're talking about, and then what's my point of reference. So if I say the ear, that's my what? Anatomy that I'm talking about. Now I'm waiting for a point of reference. I said the eye. The eye is a point of reference. So we're saying, what is the ear compared to the eye? I'm talking about the ear. Is the ear further away to midline than the eye is? And I call it lateral. If I use my eye as the anatomy, and I'm using my ear as my reference, then I say my eye is what compared to my ear? My eye is closer to midline, so we call that medial. Everybody with me? Okay. So we like medial lateral, we call left to right. It's not on here, but I'll go over it anyway. It's probably on here somewhere. I'm sorry, I didn't study the slides. But we have what's called distal proximal. So medial lateral is more left to right. So we got to be on the same kind of playing field to be left to right. When we're going up and down, we're talking distal and proximal. Same concept. I'm standing in what position? Anatomical. And what we're talking about, what's closer to the midline. But the difference between medial lateral and distal proximal is one is going left to right, the other one is going up and down. So, the anatomy I'm referring to is the wrist. Okay, I got the wrist. Now I need my point of what? Reference. I say the elbow. So what is my wrist compared to my elbow? Is it further away? So we use the word distal. If I flipped it the other way, my elbow is what to my wrist? It's proximal because the elbow is closer to midline than the wrist is, so we use the word proximal. And we use that terminology frequently, especially distal. If I say to you, hey, do me a favor, take a distal pulse, then what am I telling you to do? Take a pulse that's furthest away from what? Midline. So is that a distal pulse? Can you go further beyond here? So we call that what? Distal. This might be considered a proximal. We used to use proximal, we use central, but it means the same thing. Say it again. Huh? Yes, that is a proximal pulse of, this is a distal pulse of the upper arms, what we call extremities. But if I tell you I need you to check a distal pulse of the lower legs, or the legs, the lower extremities, you do where? The foot. Make sense? So is that a distal pulse? Yes, is that a distal pulse? Yes. Question? Stretch it. All right. All right. So we talked about lateral. Now we talk about bilateral. Bilateral means both sides. So if I say to you, the patient has bilateral symmetrical chest rise, that means what? Both sides of the chest is rising. Should that be normal? Is that normal? No? You should have one side. Save the other one for later. Right? They both should rise. So instead of saying, I got chest rise on both sides, we'll say we have bilateral chest rise. Or you say bilateral or equal or bilateral symmetrical chest rise. Or whatever. You can use any of those, get fancy if you want. Okay? But I'm good with telling me, feel, yep, He has bilateral lung sounds. What does bilateral lung sounds mean? I hear lung sounds on both sides. Okay? How about, this is a femur. It's called a femur. We're going to learn about that a little bit. If I say he has bilateral femur fractures, that means what? He fractures both his femurs. Make sense? Okay. If I use the word unilateral, yes, unilateral means one. Very good. Mid-axillary, this is your axillary area right here. All this is axillary, your side. I have an axillary on this side, I have an axillary on this side. Now, we take this axillary area and we split it into threes. So, we first get the midline that comes, we call mid-axillary, we don't call it midline. Mid-axillary splits from what? Back. Very good. So, anything above, in front of that, we call it anterior axillary. Anything back of the mid-axillary is considered posterior axillary. So if they say to you, hey, can you do me a favor? Can you listen to lung sounds bilateral at mid-axillary? Where are you going? Right here and right here. Fair enough? So saying, well, why don't you just tell me, listen to lung sounds under the armpits on both sides? That doesn't sound cool. It sounds cool to say, can you listen to lung sounds bilateral mid-axillary? Fair enough? All right. So, if he says, hey, I need you to put that mid-axillary, then you know where it's going. Where is it going? On the middle of the side. Does that make sense? Okay. So, anterior is the front. Easy. We don't call this the front no more. We now use the word anterior. As the back will be posterior, so we use back. Anything above the heart is considered superior. Anything below the heart is considered inferior. Alright? Very good. I talked about proximal distal. Everybody good with that? So what is it? What's here? Alright. The palms, that's fine. I don't worry too much about that. What position is that? Very good. Why is it the anatomical?
Upright, palms forward.
Alright, palm. I will tell you, in the near future, when you take this exam, you need to know the anatomical position. We're going to have some point of references that talk about distal, proximal, lateral, medial. So I'll say something like, what's the ear compared to the eye? In reference to the eye. What's the shoulder compared to the elbow? Proximal. Think about what we're talking about. Point of reference, okay. The anatomy, and then what's my point of reference? Simple enough. Very good. Good job, guys. This is an example. All right. Clavicle. We call this the collarbone. It's now called the clavicle. We still use the word. You just came into the hospital and say, hey, he broke his collarbone, might have fractured his collarbone. We know what you're talking about. What we should call it is the clavicle. That's the actual name for it, clavicle. So mid-clavicle means what? In the middle of the clavicle. So if you know the two ends, come to the middle. Alright? That is the mid-clavicular or mid-clavicle. We call it mid-clavicular. That just means middle of the clavicle. So if I say, I need you to go put this electrode, when we talk about electrodes, we put, paramedics put, in the fourth intercostal space, you're going to measure fourth intercostal space, mid-clavicular. They know that's going to be in the midline. Alright? Some people will say, okay, well, mid-clavicular is kind of where the nipple line is. Not all the time. When you go to geriatrics, if you follow in mid-nipple, you can put those in the kneecaps. So we got to make sure we don't use that type of anatomy. What anatomy are we using? Does the clavicle move no matter what your age is? No, clavicle's always there. The middle of the clavicle, does that change? No, so that's there. The intercostal spaces don't change neither. So I go down intercostal, I always will put that in the right place. So it might look different on different people, depending on how their outside anatomy looks, but it's always at the same place if you follow your mid-clavicular and that fourth intercostal space. Does that make sense? Okay? So that's what the point of reference we want to use, okay? Yes?
So when I say mid, it's talking about the individual side, not the...
Right, the individual side of that clavicle. So mid-clavicular, if I'm referring to, I have to give you a side, right side. So mid-clavicular right side will be where? Right in the middle of that clavicle. All right? And then left side, same thing, because we have clavicles bilaterally. What does that mean?
Each side.
Each side, both sides. Okay, all right. So you can see the directionals of terms. So by splitting us down into two halves, right and left, and then coming down this side, split us from front to back. Coming across the umbilicus, right, across here, splits upper and lower, superior, inferior. We now split into multiple halves. Now, we got the abdomen. First, we got to identify where's the abdomen. We tend to confuse where the abdomen is. All right, we call this, most people call this the what? Stomach. Nobody's stomach is that big. The stomach is an organ or a piece of anatomy inside the abdomen. So the abdomen is where your stomach is in. But the abdomen has a whole bunch of other organs. So this is not your stomach. So we can't call this the stomach no more. You can't come in and say, Doc, he's complaining of stomach pain. So they got your stomach pain. Wow, did you go in his stomach and see? And he tell you exactly. So he's complaining of what is a better word to use? Abdominal pain. Is that a true statement? Yes, if it's what? Right here. Because there's multiple organs that sit in that same location that we don't have x-ray vision to see exactly what's going on. So we say more of abdominal pain. Does that make sense? Now, because the abdominal area is big and there's a lot of organs, we want to split that into quadrants as well. And quadrants means what? 4. Quad means 4. So put it to quadrants. So what do we use to break up our quadrants as a point of reference? The belly button, known as the navel, or as navel, known as the belly button. So you find a patient's belly button and you go straight down. I went straight down, I just split what? Right from, then I take the same belly button and go across this way. I separated what? Upper from lower. So if I did that, let me draw on the board. Good thing I'm an artist. I'm going to draw you my abdomen. What's so funny? And I got my belly button. This should be right there, right? I need the 6-pack. So I go directly to the belly button, right? And then I go across. Everybody with me? So this would be what?
Right.
Right upper quadrant. Because it's the what? Patience. Right. So this would be what? Left upper quadrant. This would be left lower quadrant. And then this would be right lower quadrant. Don't worry about the organs inside there now, because we'll learn about that later. But there's so many organs, as we talked about. If you split into 4, and you say, okay, where's the pain at? Well, one finger point, and the patient points right here. Where are we at? Right upper quadrant. So now we isolated exactly what quadrant. Now we say to ourselves, okay, what organs sit in that right upper quadrant? That's going to create pain. And if you still can't pinpoint it, then at least I would tell the doctor the patient's complaining of what? Right upper quadrant. I isolated to a location of the abdomen versus just coming in very vague and say he's complaining of abdominal pain. Because if you say that, what do you think the doctor's going to ask the patient right away? With one finger points where that pain is. You say, okay, you got right upper quadrant or right lower quadrant. Does that make sense? Okay, so we split our quadrants up. And these are the organs that sit there. And we'll learn more about this later on. So definitely take a peek at these. I would say know what organs sit where. That's important to know. There might be maybe a question or two. So I will look into that. You got some key players. I'm going to tell you a good rule of thumb is if it's a hollow organ and it ruptures, we worry about infection. This is the biggest problem. If it's a solid organ that ruptures, we worry about hemorrhaging because it contains a lot of blood. So hollow organs in the abdomen actually carry a lot of waste product, bioproduct. Okay, it's not good stuff.
Holly, you said Holly, you worry about hemorrhaging?
Say again?
Holly, you worry about hemorrhaging?
No, hollow, we're about infection because you lose biocontact. You know, fecal matter, not the good stuff you want traveling in the abdomen. Okay, and then any solid organs are very rich in blood. They're very vascular. So if you rupture a solid organ, we know the biggest problem we worry about is hemorrhage. Let me tell you, 1 or 2 things normally kills patients. Hemorrhaging, infection. Those are 2 things that will put you in the grave, take a dirt nap, whatever you want to call it. Those things will mess you up, all right? So those two things we worry about when we deal with the abdomen. And infection is horrible in the abdomen. Why? There's so much in there, so many organs. It is so compact that infection could destroy a lot of these organs and they'll spread like you wouldn't believe, and it's hard to contain that. Okay? So kidneys are a solid organ, kind of semi-solid, but it's a solid organ. Anybody have any kidneys? Anybody have kidney beans? I love kidney beans. It's okay to eat kidney beans. That's what that is. It's animal's kidney. It's pretty solid. All right? But what flows through there? It's solid. So you can hemorrhage, you can bleed, but because the kidneys filter blood, so blood does travel through there. But it's so small, we don't worry too much. The kidneys are real small, super small. But the liver, that's a big, solid organ. It's huge. Look at the liver right here, guys. See the liver? It takes up mainly which quadrant? Mainly your right. So if anybody was complaining of right pain because the liver takes more real estate, what's the worst thing that can happen? Damage. What's the worst organ that can be damaged there? The liver. So I'm going to say, this is liver. If you complain of right upper abdomen, the next thing I want to feel, is it rigid? Ooh, it's swollen and rigid and hard. I'm going to assume that he's what? Bleeding inside. Think that's a true emergency? When I tell you two things won't kill you? There you go. So you got a major, major problem. All right? So if somebody gets shot in the right upper quadrant, we worry about the liver. So that's bad. So if you ever get shot, turn left. Just kidding. You can't turn left and jump. And you get the lower, you're good. All right? But anyway, you got a big organ there. You got your pancreas there. We're going to learn what these organs, their functionality is later on in these chapters. But it's pretty amazing. You're going to learn a lot through EMT school. It's phenomenal. Phenomenal information you're going to learn. You're going to learn about your organ systems, how they work, and stuff like that. Yes?
Are we going to have to know in tests, like if they're a solid organ or?
No, not yet. Just know by saying, what's a major organ in your right upper quadrant? Remember, right? I might say something like, it could be, what organ is only in your left upper quadrant? Right, look, so spleen. Right, very good. Not the heart, that's up here, you're talking abdomen. Close, but different. Sometimes you feel like your heart's in the abdomen, roller coasters, but it's really up in the chest. But those are things. Can I truly say that the liver is only in the right upper quadrant? No, because it spills over to where? The left. So does the stomach, so does the pancreas, but the gallbladder, the spleen, they are specifically in one quadrant only. So those are things that I will focus on. You need to know the functionality, you need to know that, just anatomy. Okay? Is that fair enough? Look at the intestines. Your intestines sit where? All of them, actually. Mainly the lower, but they actually sit in all four quadrants. Anybody know how long your small intestines are? It's about approximately 33 feet. Approximately 33 feet. Compact. In that much area. That's significant, right? So, and it's strategically placed. You can't just pull it out and put it back in. You would probably have some bowel obstruction if you did that. But that's why when somebody gets stabbed in the stomach, what's going to come out immediately? Small intestines, because it's so compact that once you open it up, it's like, you remember Jack in the Box? I'm really dating myself here. That was a little machine that you, and then you wait. You never know when the pop's going to pop open. This big snake pops out. You remember that? No? Okay, whatever. Yeah. So anyway, that's what happens. You cut it open, the intestines come out. So the last thing we want to do is what? Well, okay, we can't help that. The guy who he was hanging out with did that for us, so we can't control that. But the last thing we want to do is stuff them back in, because what could we do? We can obstruct it and cause an issue, make a knot. It's like, anybody ever got like a thing of string or rope and it's perfectly put together, and then you just throw it, and then what happens? It's all knot. It takes you like 3 hours to take it out. Something so beautiful. You threw it, and then just knotted up, take it 3 hours. You just like, I'm just going to cut it. Same thing here. Just jump back in, you're gonna knob out. So we don't want to put it back in, but we definitely want to cover it and prevent it from falling out. We'll talk more about that when we get to abdominal injuries. But that's why abdominal organs, abdominal quadrants are so important, because there's so much structure in there, so much anatomy that we want to isolate so we can figure out exactly what's going on. And the easy way to do that is by putting it into 4 quadrants, and we know how to identify them now. All right, let's talk about some other positions that we're going to refer to. Laying on your back, on the floor, on your back, that is called the supine position. That's no longer called the laying on your back position. So you're going to go and you'll start practicing at home. Say, your loved one, your children, hey, when did you get to bed? You better be laying supine. Really jack up your kids or your loved one, Say, I'm going to sleep tonight, supine. Alright. So supine is lying on your back. As prone is laying on your stomach. So if you say, wow, we got the patient, because that's important terminology, that's how we use it, and that's what we identify. We want to identify initially how we found our patient. So if I had a patient laying face down, that's how I document. I got a 25-year-old male found prone on the floor. Prone means you lay what? Face down. Can you lay face down on your bed? Can you lay face down on the floor? Yes. So you want to identify where you found them. I found them prone, laying prone in bed. Okay? So prone means face down. Recovery is a recovery position. It could be mainly we want left versus right. But if I am on my, what side is this? If I'm on my left, then I'm in the left side recovery position, also known as the left recumbent position. So that means I'm on my side. I'm laying down on my side, left side. If I'm on my right side, then I'm on the right recumbent or right lateral or right recovery position. You with me? Everybody understand that? We prefer left. Anybody know why?
Stomach.
Very good. What about him?
Contents 6-8 more in the stomach.
Very good. Man, and he said that with confidence. I'll come over and give you some.
I
Very
think
good.
Jerry talks
Oh.
Yeah. That's
Definitely.
that was broad.
Give me that back, bro. I thought you came up with that on your own. All right. And he's 100%. Now everybody's like, yeah, Felix, you don't know that? All right. So, if I'm laying, it's my neck, my shoulders, the arms, okay? On my left side, my stomach is like this. So the content stays where? In the stomach. Because if I flip it the other way, the right side, is the arms. The stomach is like this. So the content can come up and you can aspirate. So left is always better than right. Fair enough? Everyone understand that? Okay. What position is that? Very good. That? Anybody sleep prone? I hate you guys. I used to sleep prone when I was a kid. Now I sleep prone, my legs are numb. Anymore, I can't. I hate when people say it. They look so comfortable. They're like, God, I wish I could lay and hug my pillow like that. I can't. This one is which recovery position? Left, because she's on the left side, so left lateral recumbent position. Very good. Is this the preferred? Yes. All right. Now, this patient is sitting in what we refer to as a semi-Fowler's position. Semi-Fowler's means I'm in a 45 degree. My body's in a 45 degree. Because if I'm in a 90 degree, we call that Fowler's position. So Fowler's is in a 90, means I'm sitting straight up. Semi-Fowler's is half of 90, which would be what? 45 degree. Does that make sense? So I am laying down, but my body, where my upper body sits, determines semi-Fowler's versus Fowler's. We normally transport our patients in a semi-Fowler's position, unless they have spinal injury, we have to put them what? Supine. Very good. Very good. All right. So straight up, 90 degrees, Fowler's, semi-Fowler's, lean your back a little bit. All right. Any questions so far? Pretty simple stuff, right? All right. Let's see. I'm laying supine. You found a patient. Here's your freaking answer. All right. Come in. You found a patient laying on his side. What we call that? Recovery position. If you want to be more specific, you would need to know what? What side is he on? He's on the right side. We'll call that right lateral,
Recumbent.
recumbent. Which is a good position to be in? No, left. So I might, if I need to, change them. Who will we put on a left lateral recumbent position? A patient who might be unresponsive and breathing on their own, but unconscious. Why we don't lay them supine? Because just in case there's a possibility they vomit, they'll vomit up, and gravity is your enemy. Where will the vomit end up? Right in your face, back in your mouth, and you can what? You can choke, you go to your lungs. You know what we call that? When stuff that other than air goes to your lungs? Aspiration. Very good. So you don't want to aspirate. Anybody know, well, you probably don't. I'm going to tell you. The mortality rate for aspirating stomach content is greater than 80%. More than 80% of your patients will die if they aspirate stomach content. Question?
I was going to say, isn't it prone to pneumonia if you aspirate?
Aspirate could be pneumonia, but there's different aspirated pneumonia, meaning something other than air enter your lungs, and yep, and this is we call it aspirated pneumonia. Yep, absolutely.
Do you use the left recovery position when somebody's having a grand mal seizure?
Yes, because once again, if they what? Vomit, right? Because most likely the grand mal seizure, we'll talk about those types of seizures, very good, is they're unresponsive. So when you're unresponsive, if something's in your mouth, can you spit it out? No, because they what? Unresponsive. So if it stays in the mouth, you risk the chance of them what? Aspirate. And we know if they aspirate, we're now opening up another can of worms. Where now we're going to have severe difficult issues, and the patient most likely will end up what? Dying in his stomach content. So left lateral, if I put on left lateral, they vomit, we have an ability to drain. So it come out and don't go back. So we lean them forward with the head tilted a little bit so they can drain out. And we always have suction readily available. So it's not only want suction as quickly and aggressively as you can. That make sense? Okay, we'll talk about suction when we get into airway chapter. What to exactly do for those patients and what to consider and watch out for. So, you know, what we're giving you is chapters at a time. So a little bit. We want to learn a little bit of anatomy. Now, terminology, I should say. Because next chapter we'll talk about after break is going to be anatomy and physiology. You'll learn about these structures. And we're going to talk about that because now we're going to get into the different diseases. All these systems, we're going to recap on the anatomy of all the systems. We're going to recap on the physiology of the systems. And then now we'll talk about the pathophysiology, the diseases of these symptoms, these systems. And then once you learn about the disease of the symptoms, we'll talk about the signs and symptoms of these systems when they become symptomatic, the different diseases and how they'll present. And then we're going to learn how to assess that patient and then how to manage it. And that's what we're going to learn from here forward. So we're going to get into respiratory. We're going to get into respiratory. And when we get into respiratory, we call that what? That system, we call it pulmonary. Very good. The pulmonary system, we're going to start with a little bit of anatomy of the pulmonary system. We're going to talk about the physiology, how it functions. Then we'll talk about the diseases of the pulmonary system. Any smokers here? Any smokers? Okay, good. Any closet smokers? All right, you can tell me, I won't say nothing. Don't worry, I am going to beat you two up that I hope you quit by the end of my lecture. If not, don't worry, I'll keep checking. I'm like, you ready to quit yet? And then I'll go look, I'll follow you outside so you start. But I'm going to talk about what cigarette smoking does to your lungs. Ooh, horrible. It is the worst thing that you could possibly do to your lungs. That you'll end up becoming a patient in the future. And then those diseases and how they live and how to recognize them, what we could do as far as treating them and how to assess them. And then we're going to move on to cardiology. Then we'll move into the endocrine. So you're going to start learning about all this. Because when you go out there as EMTs, you're going to see these patients and you're like, that's what Felix was talking about, that I'm going to look like in 20 years if I keep smoking cigarettes. Got it. And then what to do. So, but, yeah, emphysema, we're going to take a break, but the big diseases you worry about is called COPD, chronic obstructive pulmonary disease. People don't realize the first word is chronic. What does chronic mean? In medical terminology, 24/7, it's like 7-Eleven. You're going to have it until you die. And by smoking, let me end it with this, we'll take a break. Smoking cigarettes has a bad chemical in it, a bad byproduct called carcinogen. Horrible. What does that do? It destroys the lining of your airway, and you destroy the most important part of the lining of the airway called the cingulate. You're going to learn about that when we talk about airway. But it's these hair-like follicles that line your whole respiratory. That is the microfiltration system of your body. Because we don't live in a bubble, and we don't live in a sterile environment. So the air we inhale is non-sterile and it's polluted. Unfortunately, the air we breathe is not the best air. But because of the cingulate, the hair-like follicles that line our respiratory, that's the microfiltration. Because we have nose hairs and stuff that does filtration. That's his job, filtrates. And when you inhale a lot of bad stuff, you end up blowing your nose. You're like, holy cow, where'd that come from? That's your hair is doing what it's supposed to do. But it can't catch everything. So the cingulate is there catching those hair-like little follicles, the microfiltration that catches that. That way when the air gets to the bottom of your lungs, it's purified. It's where it needs to be, clean, when it enters into your system. But when you smoke cigarettes, you kill that cingulate. The most important part of the respiratory, this is one of the most important part of the respiratory system. So when you kill that, then we don't filtrate the way we should, and all that pollution and stuff enters into your lungs, into your circulatory system that destroys your body. So the body recognizes that you need that. He says this is essential. We need that cingulate, but you keep smoking and you don't stop, and you're killing it. So what does he do? He says, listen, you don't want to stop smoking, but I need this filtration. I am going to change the morphology of that cell that does that. So I can still filtrate and withstand the carcinogen of smoking you do. So he changes his cell so he can withstand smoking and filtrate. People say, well, that's awesome. Once that happens, I'm good. But anytime your body changes the morphology of a cell, it becomes what we call a squamous cell, which is 100% of the time, not 99.9, 100% of the time, that's a cancer cell. It's a cancerous. So anytime your cells change, they change to a cancer cell. Now, whether it's benign or malignant is something different, meaning does it stay encapsulated, benign, or is malignant, it starts to spread. And when it starts to spread, it intertwines with all your other cells. So you can't kill it specifically. So guess what they have to do when you have cancer? They have to kill all your cells so it can regenerate. That's what you do radiation and chemo. So it actually kills all your cells and it regenerates. Why it's so painful and hurts so much. So anytime you smoke, you kill the cingulate of your respiratory tract that now is going to convert into a squamous type cell that you now develop cancer of the respiratory system. You ready to quit yet? Halfway. She's like, no, yeah. All right, still got time. Still got time. All right. Any questions so far on this chapter? All right, let's take a 5 to 10-ish minute break.